Okay. This patient's femoral this patient's femoral neck fracture this patient's femoral neck fracture in the setting of advanced CKD this patient's femoral neck fracture in the setting of advanced CKD should raise suspicion for secondary hyperparathyroidism. Secondary hyperparathyroidism secondary hyperparathyroidism is a typical complication of CKD. Parathyroid hormone release is triggered by a low serum calcium caused by the following: decreased renal phosphate excretion, decreased formation of the vitamin D, decreased renal phosphate excretion, the resulting decrease decreased decrease sorry decrease can you hear me? Yes, decrease renal phosphate excretion. The resulting hyperphosphatemia leads to formation of calcium phosphate complex in the bloodstream, binding of free calcium, decreased formation of active vitamin D. The failing kidneys are less able to convert vitamin D3, typically what is measured by the lab, to active 125 dihydroxyvitamin D, leading to reduced intestinal absorption, renal reabsorption, and bone mobilization of calcium. PTH acts to increase serum calcium, but despite being persistently elevated and cannot fully overcome the disruption caused by the failing kidney. A major consequence of persistently elevated PTH level is CKD mineral bone disorder. CKD mineral bone disorder, ongoing increased bone turnover caused by elevated PTH, can eventually lead to osteitis fibrosa cystica, a form of renal osteodystrophy, characterized by reduced bone mineralization, marrow fibrosis, and increased fracture risk. Subperiosteal resorption noted on X-ray as in this patient is highly specific for elevated PTH. Secondary hyperparathyroidism is treated by reducing the phosphorus level, dietary phosphate restriction, phosphate binder. Overtreatment can increase the risk of adynamic bone disease, another form of renal osteodystrophy which is characterized by low bone turnover and is also increases the fracture risk. Okay, yes. Renal osteodystrophy, CKD, which will decrease GFR. If there is CKD decrease there will be decrease 125 dihydroxyvitamin D, decrease phosphate filtration. One CKD will cause decreased calcium and increased phosphorus, and thus increases the parathyroid hormone. It is secondary hyperparathyroidism. So secondary hyperparathyroidism, if there is inadequate treatment, there may be osteitis fibrosa cystica, that is high PTH, high bone turnover, decreased mineralization with fibrosis and increased fracture risk. And if there is excessive treatment, adynamic bone disease, low PTH, low bone turnover, decreased cellularity, and mineralization, increased fracture risk. If there is optimal treatment, normal bone turnover. Treatment involves dietary phosphate restriction. With phosphate binder 1 phosphorus is normalized, vitamin D can be given while closely monitoring for hypercalcemia. Okay, sorry, this one. Okay. Parathyroid. Okay. Parathyroid hormone released from the parathyroid gland. It will cause increase bone resorption and increase calcium release. In kidney, it will increase calcium reabsorption, and in kidney, it will increase 125 dihydroxyvitamin D, which will increase GI calcium and phosphorus absorption, which will increase the circulating calcium, and it will give the, if there is increased circulating calcium, it will give negative feedback. Thus, PTH release from parathyroid gland will be diminished as per I guess. Okay. Increased calcium absorption. Absorption, yes. Yes. In the kidney, calcium reabsorption, but phosphate excretion. It does not reabsorb the phosphate, but in GI tract, it actually increase the calcium and phosphate, phosphorus absorption. Yes. Yes, it is not right as far I guess. Okay. This child with multiple episodes of simple cystitis, no fever, pain over past year, has recurrent cystitis. There is a variety of risk factor. There is variety of risk factor of recurrent cystitis in children. In patient, in this patient, this is most likely secondary to functional constipation. Young patients are at risk for functional constipation during times of dietary changes consistency that alter stool consistency, introduction of cow's milk and solid food, or during the onset of stressor that cause withholding behavior, toilet training, starting school or daycare. In patients who develop chronic constipation, the retained feces causes the rectum to progressively dilate. The hard stool in the dilated rectum distorts and compresses the bladder or urethra, which prevents a complete voiding and leads to urinary retention and stasis in the bladder. As a result, the residual urine becomes a potential breeding ground for bacteria that ascend through the urethra from the perineum, causing cystitis. Therefore, in addition to treating the recurrent cystitis, additional management include treatment of underlying risk factor in patients with functional constipation. This involves long-term laxative to soften stool, prevent stool withholding, and allow the rectum to return the normal size, and thereby relieving the pressure on the bladder. Okay. Yes. Inadequate treatment prior infection is unlikely due to 6-week gap because the current and prior infection. A short course of trimethoprim is adequate treatment for lower urinary tract infection in children. Recurrent urinary tract infection. Recurrent urinary tract infection can barely a sign of normal primary immunodeficiency. However, these patients have serious infection. These patients have severe infection, pyelonephritis rather than cystitis, and multiple types of infection. These patients' medical history is otherwise unremarkable. Sexual activity is associated with recurrent cystitis in women, but it is rarely the cause of children. The lack of genital injury to this patient makes sexual abuse less likely, and are a common anal fissure are a common feature of chronic constipation. A large underlying anatomic condition, vesicoureteral reflux, is common cause of recurrent urinary tract infection in infants. Vesicoureteral reflux leads to recurrent upper respiratory tract like pyelonephritis rather than the lower. Okay, recurrent infection can happen due to vesicoureteral reflux. If the scenario is like pyelonephritis, then a viewer would be the answer, isn't it? Okay. Hello, are you there? Yes. Your screen is stuck, I guess. I- Stuck. It is not moving. Oh, not really. Yes, now. S for heart sound for hypertension, left ventricular hypertrophy, isn't it? So what is our answer? Like why the creatinine and BUN is high? Protein blend and bilateral small kidney. So hypertension, chronic hypertension can cause small kidney. You, yes. Okay. This patient with no medical care in years. This patient has no medical care in years. Now has the renal disease with elevated creatinine. Now has the renal disease with elevated creatinine, bilateral small kidneys, bland urinalysis, stress proteinuria. Examination shows finding suggestive of chronic hypertension. S4 strong apical impulse. The presentation is most consistent with hypertensive nephrosclerosis. In response to chronic hypertension, renal arteries. In response to chronic hypertension, renal arteries undergo medial hypertrophy, medial hypertrophy, and intimal fibrosis, and subsequent endothelial damage leads to plasma protein and basement membrane material deposition into the arteriolar walls, hyaline arteriolosclerosis. The resultant luminal narrowing causes a progressive decrease in renal blood flow, leading to glomerular ischemia with glomerular and tubular fibrosis and atrophy, glomerulosclerosis. These changes explain the characteristics findings: elevated creatinine, decreased GFR, ultrasonographically small atrophic kidney, bland urinalysis with mild proteinuria less than 1 gram per day. Over time, anemia, and other chronic kidney disease manifestation, other chronic manifestations, fatigue develop. Diagnosis is typically inf- diagnosis is typically inferred in patients who have consistent finding with no other obvious etiology and a long history of uncontrolled hypertension, no medical care in years, fast food diet, suggestive physical examination, finding biopsy is usually unnecessary. Most patients with hypertension will not develop renal insufficiency. Risk seems increased in patients who have diabetes mellitus and have severe hypertension or are African American, positively related to APOL1 variant. Azotemia is typically slowly progressive over years and irreversible. These contrast with bilateral renal artery stenosis, present similar to which may be present similar to hypertensive nephrosclerosis, typically with more rapid and renal deterioration, but often improves with treatment, angioplasty, and stenting. Okay. Yes. Acute tubular necrosis results from ischemic hypotension, toxic aminoglycoside, and radio contrast, insult, and urinalysis demonstrate muddy brown cast. In addition, acute kidney injury often causes edema or oliguria. Okay. I don't know whose problem is this. I think that my screen. I have sent you a video. Sorry, not video. I have sent you a picture. Look at this. You are in the hypertension still now. I don't know because whenever you change, I can see, but because I refresh all my things all the time. Yes, we can go to Skype. My Skype is there. You want to do that?